Hello, I think I made it. Can you hear me?
We can hear you.
All right, great. I was on the wrong thing, sorry.
Is this Mark?
Yeah, it is.
Great.
Good morning.
Good morning.
Well, I'm going to get us started then. We'll seize the moment. And traditionally, we've had a welcome and introduction, and I would say in terms of welcome that welcome to the modern age of electronic meeting. I said before, I believe that there's some advantages to that. I think Stacy seconded that idea, and so hopefully this will go well, and we can consider using this platform in the future. I'll start out by introductions. Mike Reagan from Lubbock, Texas. I'm a family physician, a previous chair and program director at Texas Tech, now still faculty at Texas Tech, but have a role as a CMO of the teaching hospital, the primary teaching hospital here in Lubbock for Texas Tech. I'm a Texas Hospital Association appointee. There's a second one that's currently vacant. We're going to have to work to fill that. And I would let Ernest lead us around a kind of a round robin. He's going to call your name, and then if you'll do your introduction, we'll keep it organized that way.
Good morning. I'm just going to call a roll based on the list we have here in-house. So start with Dr. Reagan.
Yep, and I did my introduction.
Okay, he's present. Okay, for the record, Dr. Unger.
This is Fred Unger once again.
Oh, he's muted himself.
Fred, we lost you.
I'm back. Am I there?
You're good.
Yes, sir.
Thank you. Well, again, welcome everyone. It's nice to see everybody on this new age meeting platform. I am the residency program director at Family Medicine Residency Program in Lubbock, Texas. I am also the vice chair for clinical affairs in the department, and currently I serve you as the vice chair of the Family Practice Residency Advisory Committee. I am also now, by default, as you can tell, responsible for giving the financial report every year, but I'm glad to do it. I'm glad to do it for this organization because I believe in what we're doing, and I'm glad to see everybody.
Thank you, Fred.
Ruth Chambers.
Hi there. Can you hear me? I'm in New Braunfels, Texas, and retired and active in a lot of things here, and from Dallas originally. And anyway, grown kids and all that good stuff. So
Good morning. Great
Welcome.
to have you.
I've got 4 little dogs, little mutts here, so I will be on mute most of the time.
Sounds good. Next up, Todd Dorton. Okay. Dr. Foxhall. Not present. Dr. Brett Johnson.
Hi, Dr. Brett Johnson, Methodist Health System, Dallas, Texas, program director, and good to be here.
Good morning.
Good to have you.
Dr. Mark Nadeau.
Yeah, good morning. I'm in San Antonio. I'm the residency director at the university program here. Yeah, for this meeting, I think a virtual format's going to work pretty well. I think it's going to work pretty well for some of the education meetings we have. I think some of the other meetings are not. I think it's going to be interesting to see what happens over time, because I think some of the success of some of the meetings we're having now is based on relationships that people already have, which are forged at in-person meetings. So we'll see what happens over time. I expect we'll go to kind of a mix. It'll be fun to see what happens.
Great. Good to have you. Next up, Adrienne Pena Garza. Okay. Dr. Damon Schranz.
You're muted.
Sorry about that. Damon Schranz with the University of North Texas Health Science Center, associate professor, and I represent the Texas Osteopathic Medical Association.
Great. Thank you. Good morning.
Ernest, but can I interrupt for just a second? I got a message from Dana Sprudy and from Cindy Passmore that they need a link. They're having trouble getting in. When you get a chance, can you resend them a link?
Okay,
Are you handy for that, or should I do that?
I
uh,
said,
So, sorry to interrupt. I already sent one to Cindy Passmore. I'm working on it for Dana right now.
Thank you. Thank
Sure.
you.
okay, and someone just joined, so I'm not sure if that's Cindy.
Yeah, that's Cindy.
Okay,
Very good.
okay, next up, Dr. Warwick.
Hi, Dr. Warwick here, Baylor College of Medicine, Family Medicine Program Director, and the Program Director Organizations Rep. Good to be here.
Good morning. And our alternate member, Dr. Martin Ortega. And he is not signed on. So, Dr. Reagan, I believe we have a quorum.
Very good. I think we've got several other people on the call. We might let them introduce themselves quickly as well. Start with Stacy.
Good morning, everyone. Stacy Silverman, Texas Higher Education Coordinating Board. I'm the Assistant Commissioner for Academic Quality and Workforce here at the agency. And I'm very pleased to see everyone here, and thank you all for being on this call. Really appreciate it. And you all look great.
Thank you. I see Cindy Fisher.
Good morning, it's Cindy Fisher. I am actually a program director with the GME expansion grant at Higher Education Coordinating Board.
Thank you. And then Jonathan Nelson.
Hey everybody, Jonathan Nelson, Director of Communications for the Texas Academy of Family Physicians. Nice to be here, great to see everybody.
Awesome. Thank you. And then Cindy Passmore.
Hello. Hi, everyone. It's great to see everybody. I'm getting used to this. Yeah, we can do so much more, I think. Once you embrace it, it's a great thing. Anyway, I'm Cindy Passmore, Director of Faculty Development Center in Fort Worth. It's good.
Very good. Thank you. And is that everybody? Ernest, is there anybody else that I missed? It looks like we got everybody. Okay, well, let's go ahead and get started with our agenda. The first item right out of the gate is consideration of the selection of the chair and vice chair for fiscal year 2021. And so currently I serve in the chair role, Dr. Unger serves in the vice chair role, but those positions are up for nomination and then election. Do I hear anyone making a nomination?
Well, I'm happy with the leadership we have. So if you guys are running again, I'm not trying to unseat you, but if you need somebody to serve, I'm willing to do so.
Okay. Well, so that's a sentiment and discussion. That's good. I need a nomination from the committee, one way or the other.
Have you already been nominated?
No nominations have been made.
Oh, okay. Well, are you willing to be nominated?
Sure.
You willing to, Fred, are you willing to serve?
I'm willing to serve, sir.
I nominate Mike and Fred.
second.
So I have a nomination and second. Any other nominations? So I have a nomination and second for me to serve as chair and for Fred to serve as vice chair. Any further discussion? I'll call the question then. All those in favor of the nominations as presented, say aye.
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 I'll also point out that there's a raise hand option within Zoom if you wanted to do it that way as well. And then Ernest can look at it and mark it as well. So,
You know, that might be a better route to go. Thank you for that suggestion. Let's raise your hand if you're in favor of those two nominations.
Where's this option? Oh,
If you look at the lower right hand, there's a raised lower hand on your Zoom. You see it?
Or you open up the participants box and find it should be in there as well.
Oh, yeah, that's right.
thumbs up, okay?
That's okay.
All right.
So all those in favor, raise their hand. There's a thumbs up. Ernest, are you getting those adequately, or what do you think?
Raise
Ernest?
hand. Okay.
The ayes have it, majority.
Okay, thank you. Okay, we'll come down to the next item, but first I offer Fred an opportunity to say something if you would like, as our continuing vice chair.
Well, thank you very much for blessing me with the opportunity to be able to serve this wonderful organization and all the people that we stand for, and most importantly, what we stand for, which is training family physicians for the state of Texas and beyond, for the nation. And now they are going internationally. And so this is something that I truly believe in. And so thank you very much for allowing me the opportunity to be able to serve.
Thank you, Fred. And I would echo those comments. Living here in West Texas, the family physicians are the key person in the workforce for medical staffs across the region. And I think it's true across all of Texas. And so I agree. I believe in what we're doing. I think it's the right thing. I think we need strong voices and an advocate for family medicine across the state. And so thank you for that opportunity, and we'll endeavor to serve you well. Okay, moving on to the next item is consideration of summary notes for the May 29th, 2019 meeting. That was our previous meeting. And we sent those out. Ernest sent those out previously. Any amendments or changes need to be made to the summary notes?
This is Eric Warwick. I move to accept them as presented.
Thank you. So I have a motion. Do I have a second?
Second.
So I have a motion and a second to accept the notes as presented for the May 29th meeting from 2019. All those in favor, do the raising of hands again, if you would.
Mike, if I could interrupt a little bit, I just got a text message from Ike Okua from Odessa program. If Ernest, if you could send him a link, please. He's having trouble getting it.
Thank you, Fred. Well, a reminder about everyone, we're voting on acceptance of the summary notes, and Ernest, let us know when we're good.
Dr. Unger, sorry to interrupt, but can you tell me who is trying to get in again?
Ike Okua from Odessa program.
Got it.
Ernest, it looks like we've got 7 raised hands. Are we good? I can't hear you, Ernest.
Alternatively, we could just all say aye, and then you can ask if there's any negatives, and if there's no negatives, then it'll be unanimous.
Okay. Looks like we're good though, Ernest?
Yes, sir.
Very good. All right. Thank you. And I think Dr. Sprudy joined us. Is that right?
Yeah. Yes, I was on another device because I couldn't, that my work wasn't working with the link, but now I was on 2 devices. So I accomplished it twice after flailing for a while. Thanks, Stacy, for sending me the link. That was helpful.
Glad you're joined us, and welcome. We just approved we're on the agenda. We just approved the summary notes. So now we're moving on to the next item, which is the coordinating board update. Stacy Silverman.
Apologize. Trying to do too many things at once. I would first like to welcome you on behalf of the commissioner and the whole executive leadership team. And I just want you to know that we really appreciate everyone being here today and taking your time to talk about the important issues related to this program that you oversee and the requirements that you all are going to make today to ensure that this program can continue in the next fiscal year. So thank you for that. Additionally, here at the coordinating board, we have, like everyone else, transitioned to remote working. So we stopped, I think my last day at the office was maybe March 19th. And since that time, we have transitioned everyone, including, being able to make all our recommendations and all our payments for programs have been moved to remote working, which is actually working remarkably well. So I don't know about you all, but we've transitioned very rapidly and have moved away from paper in a way that I am very happy about. So I think we'll see some efficiencies in this remote working environment that have been a long time coming. So I'm very happy to report that. We are working alongside the different universities and the community colleges to really try and understand what their concerns are related to COVID-19 and related to, we get questions daily about when can we start back up. So I encourage you all to look at our website. We have about probably close to 80 different questions that have been raised by institutions that are out on our website that are available. So take a look. Everything from, can we change our common calendar? Can we move things online? All sorts of questions are out there. Additionally, related to financial aid, those kinds of information pieces are out there, as well as reporting information. So I encourage you all to take a look at that. I have to compliment Ernest. He has been our FAQ guru on this, posting as many questions as he can and making updates to our website as quickly as possible. So well done to Ernest, and he has my sincere appreciation as well. I will say we have a group that is talking about re-entering the agency, and I am serving on that work group to try and figure out what things need to be in place in order for everyone to actually be safe in our building. I don't know that we're going to hit that at any time soon. So our commissioner has announced that we will be remotely working through August 31st. Though people can go in and out of the building as they need with permission, and as long as they're on the okay list to come into the building. So I don't know if you all are finding those challenges on your campuses as well. And it's just a new world, and we're all kind of getting used to that. So one last thing I'll just explain. We are transitioning from our structure of thecb.state.tx to highered.texas.gov. So I encourage you to just make note of that. That is highered.texas.gov. And we made that change last week. So in terms of additional information, I'm sure you all know we got a new commissioner here in October. So Commissioner Harrison Keller joined us. He came to us from UT Austin, and he brings a wealth of information and experience from his days working at the Capitol, and also working as a faculty member at UT and in the president's office. Additionally, we have a new deputy commissioner, that is Deputy Commissioner Ray Martinez. He came to us from the Independent Colleges and Universities of Texas, where he was their executive director for about, I want to say, 6 or 8 years. And prior to that, he was a faculty member, I believe, at Rice. He also worked in Senator Zaffarini's office for several years. So we're very happy to have him here. He's been just a wonderful addition to have in our leadership team here at the agency. So not easy to transition new members to just join in, and Deputy Commissioner Martinez is our COVID leader. So he was here, he was actually in the office for about 3 weeks, and then COVID hit, and now we're off and running. So it's been a learning experience for everyone. So anyway, that concludes my report on what's going on at the coordinating board, though I'm happy to address any questions. And I know we'll probably have some later related to the legislative appropriations requests. So thank you all.
Great, thank you, Stacy. Anybody have any questions for Stacy? I appreciate the update on COVID. I think everybody's experience has been a little different with that pandemic. For me, working at the hospital, we were always open, and so everybody was working from home, and I was rolling into work every day, which is was not the norm of everybody else. But maybe we can do like a Q&A at the end about that, hear other people's experience. Okay, well, moving on agenda items. The next item is mine. It's consideration discussion of the annual written reports submitted by programs summarizing the activities of the previous fiscal year. And as always, I'm really struck by two things. One is the interest of reading the variety of different programs across the state. There are certainly similarities, but there's some really innovative things. That's exciting. And then the other thing is that I feel like sometimes it's an apples and oranges comparison a bit. Everybody has a little different world and trying to draw similarities across those. I'm just going to walk through the questions. And the first set of questions is around the numbers of positions, really. ACGME approved positions in the first year. The range was between 5 and 24, so pretty broad range. Average was 11. In terms of the total number of residents, as you'd expect, very similar, 15 up to 72 with an average of 32. So it gives you kind of a sense of the average size of the program, 11 and 32, so roughly. And it seems to me that over the years, I've been around a while listening to these reports, that number has gradually moved upward, which I view as a positive change. Relative to that, there were some questions about the size of the programs. And I think the sensitivity here is if programs were having to cut back. And it's really a mix. The majority had no change, 21. And then there were 3 programs that reported a decrease and 2 that reported an increase. And so it's really kind of, I think the general sense from my looking at the data over time, we've gradually moved upward. Again, a positive finding. The next question is really related to affiliation, particularly with medical schools. And so there were several different options. There's affiliated, located, no relation, and sponsored. I'm not sure about this is maybe an apples and oranges potentially in terms of the definition of those different categories. But as you look through those, 10 programs were affiliated, 9 were located in a medical school, 4 had no relation, and 3 were sponsored. So the general view is the vast majority are in some way associated with the medical school. And then further digging into that a little bit, the next question is around the status of third-year student training. And the vast majority of programs do serve as training sites. 25 reported yes, 1 reported no. The range, of course, was 0 all the way up to 128, and the average was 39. So quite a bit of medical student training. One of the beliefs is if you have access to students, that helps you with the recruitment of residents. And so maybe that's why there's such an active participation. I think that is also a service that the programs provide to the medical schools as a training site. I know that as class sizes in medical schools got bigger, looking for training sites has been important. And so that's a nice role, I think, for the family practice residency programs as well. Moving on down, the next question is rural or public health rotations. And there were 15 programs that had none of either, and then a smattering across the other programs of those 2 rotations. And the range was between 1 and 12 residents on those rotations, with an average of 7 per program who had rotations. So I took that average on just the programs that had those rotations, so that the ones that didn't pull down the average number. Interestingly, there weren't a lot of reported participation with the Texas Department of Rural Affairs, formerly Health Find. Really, I didn't hear much about that in the report. The next question was related to funding of those clerkship sites, third-year student clerkship sites. And 9 programs reported that they received funding, 7 reported that they did not receive funding. And then going back a year to 2018, did you receive funding that previous year? 7 said yes, 19 said no. Those numbers don't quite match up, but that was the reported numbers. It looks like that the number of supported clerkship training sites went up a little bit there. Of those, the question of direct funding, 11 answered yes, and the range was between 30,000 up to 1.1 million. And again, I think sometimes these big differences in numbers may be because of differences in reporting, the understanding of what the question was really asking. Interestingly enough, there were some comments on this question about direct funding, and 6 of those reporting talked about some formal structure as a part of the medical school, although a few griped about the low level of that funding. So not an adequate amount of funding, even though if they got some. And so kind of a range on that. Some of that may be accounting, as I said, differences, apples and oranges. Now moving more to the questions that were more commentary type questions. There was a question about the efforts to represent underrepresented populations in your residency. And there's lots of innovation here. Many reported attending national or regional meetings or residency fairs. Some mentioned presentations at SNMA or JAMP programs. So like going and presenting a lecture, I presume. 2 mentioned special selection criteria. And I mentioned this last year that one program adds a preference point for those applicants who have lived in a health profession shortage area in the past. So kind of trying to connect to that population to get applicants. A number talked about family medicine interest group presentations. Some talked about their EEOC policies. There was a mention of formal bias training. Some talked about their diverse faculty as attracting a more diverse residency group. Several mentioned recruitment from diverse local communities. Some mentioned working with diverse populations through FQHCs, and that might be appealing for applicants. And so that was kind of the range of those answers. For the family medicine 1-month rule or public health rotation, 12 programs had a requirement, 11 had electives. There were some mention about a special rural track as a tool. There were several public health rotations. One program mentioned a longitudinal community medicine rotation over the 3 years to address public health. And so some innovation there. The next question was about additional opportunities for interaction with rural or underserved populations, so interactions with patients. And the longitudinal community medicine rotation was a mentioned there. There's a master's program offering related to that population. Using rural preceptors to reach underserved populations was mentioned. A number of FQHC sites. There were some mentions of behavioral health programs in clinics in underserved areas. There were a variety of different kind of what I would describe as wraparound services like food and housing, really the social determinants of health mentioned there as an opportunity. Several clinic locations in underserved areas specifically. AHEX was mentioned. Working with local foundations to help serve that population was mentioned. There was a jail rotation and an integrated behavioral health rotation focused on those populations as well. I think that maybe was mentioned twice. Then one of the favorite questions I have about innovations in programs, a whole host, I think more than I've seen previously, of programs specifically to address social determinants of health. There was a mention of a pharmacy clinic in the family practice center, focus on holistic patient care, a number of behavioral health programs. One had a psychology intern in the FPC. There were grants to expand rural tracks to reach the rural population. There's a mention of the Family Medicine Accelerated Track at Texas Tech. Population health initiatives, number of those. There was a really interesting simulation center that was mentioned. There was a program for length of training pilot, a move to the 4-year training to have more opportunities for training broader skills. I think that's at John Peter Smith. They had a number of different optional tracks, some in OB, some specifically for underserved population. There was a program that is serving as the regional also course provider. There was a concept of a wellness center associated with the family practice center. Some mention of a innovative quality and safety committee addressing a broad population. International rotation was listed as an innovation. A whole bunch of different curricular development ideas. A number mentioned their patient-centered medical home. Again, free clinics were mentioned. Some programs are using HRSA grants to fund innovation. That was one of the items mentioned. There was some talk about using fellowships to enhance resident learning. A number of different procedural training innovations, and then an innovative research curriculum. Turning to the challenges for the programs currently, you can probably guess the number one on the list. The dollar signs. Funding is a big one. A number of programs also mentioned both faculty and resident recruitment. Interesting and, as far as I know, a new concern is health system mergers and the impact on training programs. As hospital systems gobble up each other, that might be a challenge, and that makes a lot of sense. There is also a mention of medical students not being as well prepared upon entering programs, and we've heard that over the years that potentially may be an issue. Faculty development was listed as a potential challenge. Lack of funding for that 4th-year residency training, that's specific to that program, I think, but they're looking to a way to fund that 4th year. A couple of programs also mentioned challenge of access to OB and pediatric patients, and we heard that before. I would say that's just a few programs, not broadly. Was that listed? There was some concern about lack of GME slots in Texas. A facility also was concerned about their dated facilities. One comment about medical center bias against family medicine. Lack of expansion of Medicaid, a potential challenge for all of us. I presume that lots of our sites serve as Medicaid delivery sites. Balancing education and service was raised. Duty hours raised again. CMS and GME caps to positions. I think that goes back up to the number of GME slots. The last question is how can the advisory committee help residency programs? And it parallels those challenges: dollars, looking for long-term grants, improving funding streams, sharing information from the report. And one thing that we're doing this year is I prepared and shared with Ernest these comments in a Word document. Before I just kind of scribble my notes, but now it's in a legible document. And so we can share that with the program directors so they can see the feedback. That has been a question in the past. Advocating for the 4-year training program was raised. Advocating broadly for the value of family medicine, I think a big one. Some discussion about loan repayment, trying to continue to advocate for that. And then broadly sharing the benefits of the family practice programs across the state. And I think as you think about service, so delivery of care to underserved populations, Medicaid population, FQHCs, a number of programs have those. So you got the patient care piece, you got the education piece. And as I mentioned, many programs serve as training sites for medical students. So there's the educational piece. And then preparing the professionals to go out into all of these areas. And uniquely, family medicine can really cover all areas from rural to inner city. And so I think that is a nice message to share. I think we ought to be thinking about how we can best do that. But that's really the summary comments I have, and I'm happy to answer any questions if anybody has any.
Just a follow-up comment. You had mentioned that a couple of programs had issues with PEDS volume. And I think if you look at the program director's listserv, that's a nationwide problem. I think a lot of programs have trouble with that.
You know, my own reflections on that are that there may be better volumes in the outpatient arena than in the inpatient. Inpatient seems to have really tailed off quite a bit, just because of the nature of practice. I don't know if that's what you were referring to or if it was outpatient as well.
Well, it's both. I think so much of PEDS has gone from inpatient to outpatient that a lot of programs have trouble getting any PEDS inpatient. But I think there's a lot of systems where they really they got pediatricians, they got to feed that beast, and so they. I think that's a pretty common problem, is all the point I was making.
Well, maybe development of hospitalist services have impacted that too. I know at our facility we have pediatric hospitalists, and they do, as you use the word feed, but that is absolutely true. So I don't know if there's any thoughts about how to address that. Anybody have any thoughts?
I think one of the things that, as you said, Mike, that we're really having issues with pediatrics. A lot of pediatricians are no longer practicing in the hospital. As a matter of fact, even here at Texas Tech, I can't count with one hand how many pediatricians in town are doing any inpatient work at all. Most of them have gone to giving up all the inpatient work to hospitalists. And then we have a sister hospital here that is doing most of the hospitalist work for inpatient work for pediatrics. And they tend to be territorial. And I think one of the things that we must work really hard to do is to make sure that we have relationships with the program directors in those departments. So at least we have a voice coming from the program director, somebody a little bit higher up, speaking for us in inpatient environment, so that we can have space there. And one of the things that I've done is also got myself in the emergency room just so I can tell them that my doctors are very capable of working in the pediatrics environment, and they're capable of doing the work, and it gives me a leg up that way. But I'm seeing nationwide that that's becoming a huge problem for family medicine, and it's something that we may have to talk to our SGME, residency coordinating service to see what we can do nationally to be able to change that. But it's going to be an issue going in the future.
You know, one thought I had is, if you can't beat them, can you join them? Could you use the hospitalist services to train residents potentially? I don't know how feasible that is everywhere. It probably varies by location.
So you can use it to get the residents experience. It doesn't help you with the ACGME requirement that you have family physicians role modeling care of inpatient pediatrics.
Yeah.
So you have an issue with that.
Do you know, I haven't seen lately the data. Is that a frequently cited citation?
It's not uncommon.
Yeah.
Dad and maternity care.
Mm-hmm.
A number of places are just having a problem with inpatient adult care, but that's much, much less common.
And I think there too, hospitalists may be competing for those patients as well, kind of in a broader expansion of hospitalist programs. Okay, well, any other questions or comments? All right, we'll go on to the next item, which is the consideration discussion of the financial report. Dr. Unger.
Thank you very much, Dr. Reagan. And again, thank you very much for everybody participating in such a palpable way. It's a different platform, but it's working. At least I didn't have to worry about being at the airport and with all the COVID issues and double masking, and my hands are just dry and just coming apart from just all the chemicals that I don't even know how many chemicals I've gotten into my hands. I don't even know what they are, which is really sad. One of them I used yesterday. I thought I was drinking tequila. It was so hard. It was so harsh. So it's just amazing. And I hope you guys are doing well out there. So for the financial report, if you just bear with me, it's always pretty extensive, but I'm going to try to shorten it as much as I can. And so for the fiscal year 2019, the total number of programs funded were 26. Missing from the 2018 spreadsheet, which we had 29 programs then. 3 of them have fallen off the list, which number one that we all know about is the North Central Texas program, the North Texas Medical Foundation, Wichita Falls program, fell by the wayside, funding issues as well, and the realignment of the hospital, which was the biggest thing. And the leadership just did not see that they needed the residency program. And so I believe it's just a matter of time before they come around and try to talk to us about restarting another program. That tends to be the issue that happens over time. The next program that is also missing is the Bay Area program in Corpus Christi, which is the UNT Health Science Center program that was once again nixed in favor of internal medicine. They expanded the internal medicine opportunities and cut off family medicine completely. And then lastly is the UNT Health Science Center TCOM Family Medicine, which is now combined in the current spreadsheet. So they really haven't disappeared. It's just now UNT TCOM Family Medicine and the NMM program that they have there. So we appreciate what they're doing, and they're doing a great job with it. So 27 programs have submitted an annual financial report. 26 programs show up on your list, as we said. But that is because of the combined family medicine and the NMM program at UNT TCOM. Total number of residents funded was down from 773 in 2018 because of those programs cutting down and just disappearing from our list. And it went from 773 to 749 in 2019. I believe Ernest sent everybody a spreadsheet, so at least you can follow along. It's just a lot of numbers that I'm going to be talking about. And so just bear with me. And if you have any questions, we can ask them, and hopefully we can come up with answers at the end. There was a correction that was made last night with between Ernest and myself. And so if you have the old report, please disregard. There's a report that I believe Ernest sent you guys last night, which has consolidated all the numbers and they all match up. So if you have the old report that was sent a week ago, there's a number of residency slots, which was 749 on the current report, and it was short 24 residents. But we found those 24 residents were all hidden within the UNT TCOM program, and And so the report that was sent yesterday is a correct report. Okay. Again, as in previous years, the total revenue generated by each program varied from 1.76 million at Baylor University Medical Center to 23.3 million at Conroe Medical Education Foundation, which is the Conroe program, the AHEC program. We must not look at those numbers at face value because all programs have different revenue sources, different funding programs, and revenue opportunities, both locally at their residency site, locally at the hospital itself, and some have local state funding of different funding sources, but a lot of them also have government funding, which is federal dollars that you cannot compete with that. So if you look at your numbers and they look really bad, it's not because you're really bad. It's just because there's so many different revenue sources that and different contracts that programs have that vary between or among programs. Okay, if you look at the coordinating board operational grant, we had 4.822 million supporting a total of 749 residents across the programs. These grants are based on certified and approved resident slots on each program. In each program, the number of residents varied from 9 at Baylor University Medical Center to 67 at JPS. JPS will always lead unless somebody else like Odessa Permian. The Odessa program is really fast chasing JPS as far as the number of residents is concerned, and we'll talk about that later, but JPS had the biggest number, which is 67, which hasn't changed very much in the last few years. The operational grant total average per program was $185,461. Per resident funding was approximately $6,438. Okay, so we had a total of $4.822 million over a spread over 749 residents. Once again, $4.822 million over 749 residents. It came to about $6,438 per resident. So the coordinating board grant reallocation. So we had $233,100 to all programs with an average of about $8,965. These once again were reallocation programs, came back later. No monies were expended on public health rotations at any of the programs. So no programs applied or received monies for public health last year. So the rural health rotations, we had 10 programs participate in the rural health rotations. We had $92,500 expended on these rotations, with Texas Tech Health Science Center Lubbock, which is my program here, had a total of 11 residents participating at a tune of $2,500 per resident. So we had the lion's share, and I appreciate that very much, of $27,500. These were all approved rotations by the coordinating board, and we always report the participating site. We have feedback from those sites that is shared with the coordinating board. And unfortunately, with the COVID thing that has happened on us, that actually landed on us nationwide, it's been very, very difficult for those rural rotations to accept residents from anywhere. Lubbock is considered the place where University Medical Center, where we are right now, our teaching hospital, is considered the place where people with COVID or COVID positive patients that need hospitalization come. Of course, the way you know, the residents are the biggest workforce that we have. And so these rural programs, rural hospitals that we have, they really have a hard time having residents coming from Lubbock with potential exposure to COVID, just because of the fact you take care of these patients coming out to those hospitals and potentially exposing them. So some of them have basically told us, hey, no, wait, we'll just hold off for now. And we're trying to keep the coordinating board informed as much as possible, make sure that we don't miss out on those monies. Okay, so last year, the coordinating board total grant, we had $5.15 million, $198,000 average per program, $60,742 was the lowest average given to Baylor University, with $462,191, which was the highest amount of money afforded John Peter Smith Hospital just because of their sheer size. Only one program, that is UT Tyler, had $1,695 in interest that was given back to the coordinating board. If you keep any money in the bank and you don't expend it and you gain interest on it, you're going to have to give it back to the coordinating board. That is not money that any program can keep for themselves. That's not money earned. That's money earned for the coordinating board and needs to go back. So if you look at the family practice residency program patient revenue column, as you can see, there's lots of disparity among the programs and the range is wide, okay? There are some have reported zero revenue at, for example, Texas A&M program at Scott and White and Baylor College of Medicine. And you also have numbers as high as $15.6 million reported at Conroe AHEC program, that is a medical education foundation. The main reason for this, again, this large disparity amongst the programs because of the different revenue sources that we talked about earlier, the different sponsoring dollars from the sponsoring institutions. And once again, some of the programs have local funding from local foundations that support those programs. So they have so many other areas of garnering revenue into their programs. And so when you see zero reported, it's not that the residency program did not earn anything at all. It's just because the way they report their revenues is different from the way you may report your revenues. For example, revenue, as you can see, is money's coming in, and it depends on who's capturing that money and how it trickles back to the residency program. And so if you see a program reporting zero, for example, Baylor College of Medicine, it does, or Texas A&M Scott and White, does not mean that they have no revenue at all. Nobody can survive like that. It's just because who's picking up that money and how it trickles back to the residency program is different. Okay. So I personally would like to commend the programs for doing so much work with so little. And we're training a lot of residents, and we are getting very smart as far as getting money, getting funding. Even here at Texas Tech, we really work very well with the hospital system to try to get us as much money as we can in order to keep our program as big as it is, because the need out here in West Texas is tremendous. And we are very proud to report that we're still putting over 50% of our residents in rural West Texas, and that makes us feel very, very good. Okay. So how do residency programs generate money? Just basically direct provision of healthcare and health-related services. Some programs have very high different structures for end contracts that they have to use, or they've affiliated themselves with over the years. And so there's so many different third-party payers that they're using to be able to generate revenue. And so I would encourage our programs to look at what you have in your institution or what you have locally in your region, in your area. If you can affiliate yourself with a local community health services, for example, and see if they can share their dollars with you, that would be great. Because as you can see, the dollars are shrinking every year. Okay, so again, the total biggest revenue earners were Conroe, McLennan County, which had 12.2 million. Conroe had 15.7 million, and of course JPS was a distant third at 6.98 million. So once again, congratulations on the work that you're doing. The total number of revenue generated by all programs were $82.8 million. I know it's a lot of numbers, guys, just bear with me. And the average revenue per residency program was 3.18 million. Once again, that's a skewed number because we have at least 3 programs reporting zero, and the average goes amongst all the programs. And so $3.18 million per program on the average does not really say the truth about all the money that's being earned, just because of the way we report our revenues, who captures it, and where it goes. Okay, patient revenue per resident was $2.8 million with an average $107,790 per resident. Again, another skewed number because of what we've talked about earlier. How about medical school revenue? Medical school revenue comes in the form of the sponsoring institutions. For example, at Texas Tech, I'm using us because I know what we're doing here and I don't know what other programs do. We do a lot of teaching for the medical school, a lot of teaching for the medical students. And we also are involved in a lot of other programs that the School of Medicine requires to teach, in order to teach medical students. And so those come with some inconveniences to our program, because when we cannot see patients in our clinic because we're taking care of medical students, for example, we are teaching in the School of Medicine, that is money, that's revenue that's being lost by our residency program. And so our dean is generous to be able to give us some money back in order to be able to basically indirectly pay for those services or directly pay for those services. So different participating sites have different revenue sources with their medical school, and those numbers are self-explanatory. I don't need to go into the details. They're right there in front of you for you to see. Once again, some programs report zero, some programs report upwards of $2.9 million. UT Tyler, for example, that's a lot of money from the School of Medicine. The average, again, is skewed because if you have a program reporting zero, somebody's reporting 2.9 million, average is $443,123 per program. That is, it's a big number, but it is not quite as big as it could be if all the programs are getting money. Next is the hospital and local revenue. Okay, again, I don't want to sound like a broken record. There's so many different programs out there that, and hospitals, and how they designate monies going into residency programs is different, and some have bigger coffers, and so they can give big monies, and some don't have very much. And so any money is good money as long as it's used appropriately. But the range from all this hospital and local revenue was about $787,000 at the UNT TCOM program, and all the way to $9.3 million at Memorial Family Medicine program in Houston. $9.3 million. That's a lot of money. I'd like to talk to them and see what they're doing and how, if we can duplicate that here. One of the things that I've noticed just reading over, as I was looking at this financial report, and I look at the hospital districts and how they are aligned, there's different tax bases and tax brackets and tax averages or percentages that all hospital districts have for their local hospitals. So, for example, Tarrant County has a huge amount of money that is being taken away or taxed the local people in Tarrant County, and a good chunk of it goes to JPS, and really appreciate what they have over there. And then I realized very quickly, Mike Reagan, that we don't have a hospital district in Lubbock, Texas. I've actually looked into that, and UMC does a lot of work for teaching, and has produced tremendous number of doctors over the years, but we really do not have a tax base that supports the hospital for all the work that we do. And so I don't know how we can change that, and hopefully we can have reflect at least a half of what Memorial Family Medicine program is reflecting in Houston. So that's something we can talk about another time. The total number of monies coming in was $93.7 million from the hospital and local revenues. The average is about $3.6 million per program. And the average per resident was $129,228. That sounds like a whole lot of money if you don't have the monies like we don't. But for the people who have it like the Memorial program, I think that is something that is commendable. On the local revenue alone, most programs got nothing. Most programs don't have any local funding that is coming directly to them. But the three top programs with the local revenue were UT Houston at $4.3 million. And I really do not know what that local revenue means, if it's taxes from the community, if it's some kind of arrangement that they have with the communities that they exist in to be able to make those monies. And Ernest can probably clear that out for us later on. UT Houston at 4.3 million, Baylor College of Medicine Houston had 1.4 million, and Texas Tech Amarillo had 1.18 million. That could be oil money or cotton money, I don't know, but it's good money. There's also federal revenues are reported. The only program that reported federal revenues was Conroe Medical Education Foundation. The AHEC program reported $5.0 million in federal revenue. That's huge. No any other program had federal revenues reported. Okay, there are also other sources of revenue that was reported, not necessarily reporting exactly what other meant, but Texas A&M College of Medicine had $2.9 million in other revenue. UT Southwestern had $2.3 million, and most of that being a graduate UT Southwestern, there's a lot of foundation money that comes into the programs. McLennan County had $1.5 million, and UT Tyler had $1.23 million. Just huge money, but much appreciated. And then as we move forward, I look at the total expenditures per program. Bear with me here. And the total expenditures, oh my goodness. I'm sorry guys for that noise, can't control that. It depends on the size of the program. Once again, the biggest programs were with the total amount of expenditures were Conroe was the highest at $22.8 million. And this depends on all the services that they provide. The more services you provide, the more involvement you have in your local area and beyond, the more expenditures you're going to have, as you can tell. And the lowest of these was at Baylor University Medical Center at $2.1 million. The average total expenditures were $7.8 million per program. The total cost per resident average was $279,419. The resident cost, including salary, fringes, etc., was an average about $2.1 million per program. The highest cost, as you can tell, went to JPS at $6 million just because of the sheer size, and the lowest of UT San Antonio at $183,000. I don't know how they're doing it with that low money, but obviously they figure something out how to cut expenses and keep it low as far as residency is concerned, unless the salary is just so low, but they can convince quality residents to come there. So Nadeau can tell us more about that later. The faculty cost on the average was $2.5 million per program, with the highest again at UT Houston and the lowest at UT Health Science Center TCOM program at $5.1 million versus $246,000 respectively. The rest of the report is just general information and general detail that you guys can look at yourself. It's pretty self-explanatory. I'm not going to go into all this minute detail as far as cost for nurses and this and that is really not important at this point, but you can look at it just so you can compare your program with every other program. And that pretty much concludes my report. I would like to add a little bit more to that, and then I'll be done. Basically, as you can see, the mail that we got from Ernest last week show that we have 4 new programs that will be eligible and approved for funding in the fiscal year 2020. And these are the Victoria programs, the DTAR program, healthcare center in Victoria, Texas, Doctors Hospital at Renaissance, which is UT Rio Grande Valley, Texoma Medical Center, and UNT Tyler. I believe that's their 1-2 program that's now a standalone program in Pittsburgh, which is a small town out there in Tyler in East Texas. So we need to keep an eye on that as we're spreading out the monies. And then of course, in 2021, we're going to have the Texas Institute for GME and Research, which is going to be 24 residents. The Rio Grande Valley program, which is 18 residents, the Scott and White program at Round Rock, which is another 18 residents. So in 2021, we're going to look at 60 new residents that are going to be asking for funding. So I just want to give you guys a heads up before we move on with that. As we speak right now, we have about $5 million to spread over what's going to be 874 residents this coming fiscal year. So we are looking at anywhere between $5,400 to $5,800 per resident this year. So that's going to be a significant drop from last year, about an average of about $1,000 per resident, and that can impact some programs. And so we need to also have discussions about that going forward and see if there's any other things we can do to be able to at least help out programs that may struggle beyond what we want. The one thing that we don't need is for programs to cut down their sizes, especially if they have the patient sizes to be able to support their residency sizes. It really hurts when we lose residents and we lose residency slots, because as you know, you lose them permanently. The hospital districts and teaching hospitals these days just don't have that much more money to be able to support programs. And so if you cut, the likelihood that you're going to expand is pretty low going forward. And so that concludes my report. Dr. Reagan, any questions?
Brett, thank you for that report. Lots of figures. It's always interesting to compare programs and how the training for residents is funded. Any questions for Dr. Unger?
Yeah. Hey, Fred, it's Brett. How are you?
I'm very well, Brett. How are you doing?
Good. Hey, the one column that concerns me is column Q. That's the patient revenue per resident.
Yes.
What am I doing wrong? I mean, we're at 54,000 per resident, and Conroe's at 522,000 per resident. I mean, that's a huge discrepancy. Do we know why that discrepancy in column Q between all the programs?
Actually, that is one of the things. Once again, the way the programs report patient revenue are very different. once again, revenue is interesting in that if you are capturing the monies, it's easy to track it the way it's coming in and the way it's going out. And so it's easy to track it that way. But because of the different contracts and the different affiliation agreements that hospitals and sponsoring institutions have with residency programs, a lot of times revenue is reported, but who's capturing that revenue? And so if you see a number like 0, for example, like I said earlier, it does not necessarily mean that, it doesn't make sense that a program is not reporting any monies at all, any revenues being garnered from their program. It's because who's capturing the revenue and how it's being reported back is very, very different. That just depends on the contracts that they're signing and the affiliation agreements. It's tough. I wish we could just come out and say, everybody, hey, this is what it is. And so the average is going to be higher for programs that are huge and probably smaller for programs that are small. But when you see revenues being reported at 0, it makes the averages, the skew just huge. And so that's the way it is. Ernest, do you have anything to add on that?
No, sir, but we could definitely take a look at those reports and follow up with the field and make sure that, if there are any questions or any uncertainties on how those items are reported, we could definitely take a look at that. I know that the report's always something that could be quite confusing on how revenues are reported, expenditures, and it's an item that I think we hope to look at each and every year, but permitting time, it kind of falls through the cracks. But we can definitely, I know in the past there's been some talk about distributing the template and having a discussion about some of those items and how they're reported by the program. So we could definitely follow up with that for sure.
Yeah, it'd be nice to have like a little study guide in terms of, okay, for this column, this is exactly what we mean by this. Because otherwise, I think people are throwing in other things. People have to be looking at it differently to have a discrepancy like that. There's just no way that a program can be making $522,000 per resident. I mean, I'd increase my residency by 1,000 residents if that was the case, you know what I mean?
That one thing I think that is different is that I know that Conroe and Waco are both federally qualified health centers, FQHCs, and their money just is different because they get paid at a different level because of that designation. And I don't know what other FQHCs there are in Texas. I don't know that, which ones are affiliated with residency programs, but I know those two are, and that does make a difference. But like you said, but it's all in how the decisions are made to report. And I don't know if anybody that remembers back to the days of Jane Allison, who was a renowned administrator in the state, and the committee work that went on to standardize the way the reports are done. And it's a very difficult undertaking. And I just because of the way that people do their books. I don't think anybody's disingenuous at all. It's a really difficult to make. It really is apples and oranges.
Right, and I agree. I mean, I think where I could see this of value is that if certain residency programs are doing best practices and really generating more income, it's great stuff to share amongst each other because we all want to do as well financially as possible. So I just don't know if anybody was doing something really great that I should be catching on to.
Actually, another way that I look at that is I have the opportunity to look at my senior residents contracts sometimes and where they're going in rural West Texas. And I'm seeing, for example, just looked at a contract from one of our residents that is going to a critical access hospital in rural West Texas, all the way close to New Mexico. And for every patient that he's going to see at his clinic, he's getting paid $93 regardless of what. It doesn't matter if that resident has funding, that patient has funding, whatever. If anybody that walks into his clinic, if it takes 2 minutes, 2 seconds, a quick swab, your flu is negative, bye-bye, he gets paid $93 per patient. And then I'm looking at places where they're going to be paid $38 per patient. And I'm saying, my goodness, where are these monies coming from? You can just see right there that critical access hospital has been able to tap into some serious money. And so for this person, these two people are reporting revenue. You can just see how huge the difference, the disparity is going to be. If they see 1,000 patients each, you're looking at $93,000 versus $38,000. And so I think this is what's happening with these AHEC type programs where they're getting so much federal dollars, so much local funding. And so per patient visit cost or whatever the report is going to be huge depending on that patient has funding or not. And for us, that way out here in West Texas, we have these people who don't have funding. We just have to see them for nothing. And so in programs like Conroe, and I'm speaking out of turn here, I'm sorry if I'm speaking out of turn, it probably doesn't matter who shows up. They get paid a certain amount of money. And so you're going to see some huge dollars there where programs like myself, we're going to have zero reported in that column. And just like these residents, $38,000 versus $93,000 for seeing 1,000 patients, it's just huge disparity right there, as you can see.
So I have a suggestion that might get at the point Dr. Johnson's trying to reach, and that is we could consider adding in the written report a section on financial innovation. And so we talk about curricular innovation and those kind of things, but we could ask a specific question about how you are innovating in terms of funding. We may hear something about the FQHCs that Cindy mentions. We may hear other ideas, but that might be a way to get at it. I do think all the comments are true. I recall at least twice we've tried very substantially to improve the financial reporting, including the descriptors about how to fill out the report. I think it's probably worthwhile maybe to do both, to have another run at education of what we mean by the different fields. And that's probably best done by administrators at the different residency programs. And we might look at a process similar to what Cindy mentioned when Jane Allison chaired that before. That's an option. And then I think we ought to consider adding a question on the written report related to the specific innovations in funding the education. That might be a way to capture some innovative programs that might be useful for others to consider. And I do think that's a value that we could offer, sharing innovation across all different areas of resident education, including the funding.
Great idea.
One more thing, Dr. Reagan, in terms of the report, I know Cindy Fisher and I have had this discussion also because GME also requires, annual financial reports. The issue with, who's actually collecting the data and preparing the report, it could jump several offices by the time it reaches the program director. And I'm not sure if there's, enough communication between the different offices to verify, those numbers once they're prepared and ready for signature and sent to the coordinating board. So I know some of the descriptors, there is an actual tab for the report itself that outlines some of those descriptors, and they may be outdated and not very detailed enough for the programs, but that's certainly something that we can also look at and make sure that we're up to date with those descriptors and make this make the report a little more friendly for the folks to fill out.
Okay, we got a couple of action items to work on there. All right, so any other questions for Dr. Unger? Okay, hearing none, I'm going to move on to our next item, and this is a voting item. It's consideration discussion of the family practice residency program eligibility for family medicine programs funded under the GME expansion program. And those of you that attended last year will remember a discussion about how we approach this. So programs that are new programs coming up in the expansion program, when do they get included, or do they get included in the coordinating board grant funding? Last go around, we added programs who had a 3-year history of operation. I think the discussion at the time, as I recall, was that if you have a 3-year track record, you're going to make it and be a functional program, and so that would be a consideration. And we have, I believe Fred already mentioned this, we have 3 programs that have met that 3-year threshold and are up for consideration. And Ernest, do you want to walk us through those 3 programs?
Sure. I was thinking maybe perhaps have Cindy do an overview of the GME program, and that'll kind of segue us into these programs and then on to the funding item, since they have to be voted separately. Yes. I think the GME overview was part of the agenda last year, and we weren't quite sure how to fit it in this time because of time and whatnot. So if Cindy, if you're ready.
And one thing I would add to that is I think there are 3 programs up for consideration this year that have met the 3-year threshold. There'll be 1 in 2022 and 1 in 2023. Is that right, Ernest?
That is correct. So potentially adding about 104 positions within the next 3 years.
Okay. And then I guess we're turning to Cindy for an overview.
Hi, yes, thank you. And thanks for having me and allowing me to fill in after Suzanne's retirement. I'll try to do this as good as she was doing. And I'll be pretty short today. What I wanted to mention first was the appropriations that were received for fiscal year 20 and 21. For the GME expansion grant itself, we received $156.7 million. There's also a $500,000 planning grant appropriation. And then out of this amount, we awarded in January of this year, made awards to 95 programs. We're in the process of doing verifications now to make sure that those programs filled their spots. We've actually had one program that didn't make it, new program. So we are down to 94 programs, and this covers 2,028 residents for the 2-year grant period. And so we're at about 152.1 million right now. I have about 10 programs that I still have left to verify, so that number may change slightly, but probably not by too much. And so the breakdown out of all these awards for family medicine this year, it's about 23% family medicine programs. Those are 20 family medicine programs. Primary care for family medicine, internal medicine, OB-GYN, and pediatrics is at 62%. And psychiatry, which includes IM Psych, is 16%. And so total for primary care and psychiatry is about 78% of the awards. We are just about to start the process for the payments. And so we'll start that process next week. And so over the next few weeks in June, we'll start getting those payments out to the programs. That's pretty much all I have for GME at this point, unless anyone has any questions.
So, I think one of the questions always is the ongoing funding of the programs. And could you speak to that question?
And I probably is going to give the same answer that we give every year, is that it just depends on what's going to happen for the next biennium. When I look back, we've greatly increased from, fiscal year 14 was 14 million, 14.2 million. And last biennium, we got 97 million. And so this year we're at 157. So far, it's been good. I don't know what's going to happen. We're hoping that this is going to continue. Every year, we see the positions increasing, and new programs coming on board, new medical schools creates that need for the 1.1-to-1 positions, and so that's going to keep the need up. So hopefully, the funding will continue.
And so far, the programs that have started have had continued funding. Is that right?
That's correct. So the programs that started in 14 have been continued with the funding. This last group that we had in 18, we didn't fund any new programs. This year, we funded quite a few new programs, and we continued those programs that were already receiving, maintaining their positions that they were receiving funding for.
No one has a crystal ball and can see the future. I would say we've talked several times about COVID and its impacts. I get a newsletter I read yesterday talking about the economics of this whole deal. And I think the effects of COVID are going to be felt reverberating out into the future. One of the figures that was presented was that 1 in 4 people in the workforce is currently unemployed. Those who could be employed, would like to be employed, 1 in 4 are unemployed. And that just has a ripple effect, I think. And so it is an open question, probably more so this year than in past, as to whether there'll be strong revenue at the state level to support continued funding and growth of funding as it has occurred. No one knows, but there is certainly some worry about that. Okay, and Cindy, is that the end of your comments?
It is.
Okay.
Unless anyone has questions, yeah.
Okay, and Ernest, anything to add there? Ernest, I don't hear you.
How was that?
There you go.
Okay, I'm sorry. It's something with Zoom for some reason. It likes to mute the mics for some reason. So apologize for that. So up on the screen, I'm not sure if you guys can see that yet, but that's a snapshot of the 3 programs that are funding eligible for fiscal year 21. And these are the institution that we'll discuss and vote on to allow into the program for fiscal year 21. Like Dr. Unger mentioned earlier, that each time we add a new program, it will affect funding. And at the current level, it's a big hit, of course, and that's something that we're lobbying for every year to increase funding. So with that, it's basically our job to vote on these and discuss these, and of course discuss the additional impacts on family practice. So with that, I will turn it over to the committee for discussion and a vote. Also, if you remember, last year was actually 7 programs, but these 3 listed here were not actually eligible. So that's the reason why we only funded 4 of the programs last year in fiscal year 20. And now these have now met that 3-year threshold and are eligible for fiscal year 21.
So the 2 at the bottom are not eligible? Is that why they're not in the final tally at the bottom of 60?
Correct. They have not met the 3-year threshold. They will be eligible fiscal year 22 and fiscal year 23 respectively. So we're potentially looking at adding 60 positions this next funding cycle.
Mike, I can see you talking, but I can't hear you.
My apologies. So does that make sense? So three are eligible this year based on the 3-year threshold. The Laredo program will be eligible the next year, and you'll note that it is not supported by GME expansion. And then HCA, Gulf Coast, and Houston will be eligible the following year. So 3 in 2020, 1 in 21, 1 in 22, as you march out that 3-year expectation. I'm going to restate what Ernest said in a slightly different way, because I've always been sensitive to precedents. When you set a precedent in your programs, whether it's salary or whatever, a policy, standing by that, I think, is an important concept so that everyone's treated the same. And so the precedent that we set last year was to add programs that were eligible. And I think we have that list that was in the email that Ernest sent out. The Victoria program, the Hospital at Renaissance, the Texoma program, and the Tyler program in Pittsburgh. And so we have that from last year. We still have to vote this year on these programs. And so with that said, I'll open it up for discussion if anybody has any comments.
Well, as the family gets bigger, there's less money for each slot, but unless the legislature comes up with more. But I think that we just add them in. I think that's the right thing.
you know, I do, go ahead.
So Dr. Warwick here, family medicine. Each year this kind of comes up, and I'm just always wanting to have clarification from the CV that those programs that are getting grant funds through a separate grant, that they are in fact indeed eligible by law or whatever governing body is covering these grants to also be eligible for the family practice grant.
That is correct.
Great, thank you for that. I just like to always get that on record.
Both good points. Thank you. Other discussion?
You need a motion to approve?
We do.
So moved.
So you move that we
And I'll
accept
second.
the 3 new programs who are eligible.
Yes, that's my motion.
Okay.
Dana Sprudy here will second.
So I have a motion and a second to accept the 3 programs indicated that are eligible. All those in favor, I guess we'll do the raise your hand vote and count that. Ernest, let us know when
We have 8 yeses, so motion
sounds
passed.
like the motion carries. Okay. Very good. Thank you. Okay, and so we are moving on to item 8, which is the consideration for fiscal year 2021 funding recommendation. And I believe Ernest has got some options for us. Do you want to walk us through those?
Yes, sir. Let me get them on the screen and we'll walk through those right quick. Okay, let me know if those are visible.
Yes.
Okay. So the first section is the what's happening this current year, snapshot of how we will end the year once the August 31st date comes around. So we started with an appropriation of $5 million. We funded 31 programs, 814 residents at $5,889. We supported 42 rotation awards at $2,500. And FDC support was $101,009. It was a slight increase from the original approval from last year. And what happened there basically was we did not receive any public health rotation applications. So with the guidance of Dr. Silverman and Dr. Reagan, we shifted that money into 2 additional rotation awards, which brought it to 42, and reallocated $1,000 to the FDC, and the $9 basically was the residual amounts left over after the main allocations were run and rounded. So that rounded out the FDC support. So next we have some funding scenario options that the committee can discuss, and of course propose additional options if necessary. So the 2 assumptions are as follows. Assumption A allocates the money at the 2020 level. So that would keep the 31 programs currently funded at 814 residents. The 3 options, the difference in the 3 options are the FDC support amounts. So option A funds FDC at $100,000, option 2A, $50,000, option 3A at $0. And your far right column will give you the breakdown of the per resident amount. So you'll see $5,889 for option A, and that'll slightly increase as the FTC support drops off. Assumption B now adds the 3 programs, of course, and starting from left to right, $5 million appropriation, funding 40 rural rotation awards, 3 public health awards, the FDC support following the same suit as assumption A with the decrease in FDC support as you go down the options. And then of course, you'll see the per resident amounts. Option B, 5,485, option 2B, 5,500, and up to 5,600. So you'll see some slight differences, from both options. So now that the motion is carried and we've, approved the 3 programs, we'll look at assumption B and open it up to discussion for the different option scenarios. Dr. Reagan?
Ernest, this is Dana Sprudy. Could I ask a question?
Yes, ma'am.
So, and I'm sorry, I don't remember the details of that, but my understand, as I recall from the participation of programs for the rural rotation and the public health rotations, that are all of those funded slots used? And then the second part of the question, if they aren't, would it be, and I don't know if those numbers are written by law, but if those numbers aren't used, can some of the unused funding from unused rural rotations or public health rotations be funneled back to the general pot?
Yeah, so the short answer is that if the money is not used, it does get reallocated. And Ernest is nodding his head, so.
Okay, thanks, Mike.
You bet.
Sorry about that. I'm not sure if you can hear me. It's
yes.
Issue with the microphone. Okay, so yes, you're correct. We usually funnel that back into the main program and make some reallocations depending on the time of year. A lot of the times it may be too late. For example, this year we have roughly about $40,000 that is pending, and that we will move over to fiscal year 21 to make additional allocations or add to the appropriation for fiscal year 21. We did get word a couple of weeks back that some of the rural rotation supervisor locations are not accepting the rotation. So some of those applications have been withdrawn. So I think it's about another $7,500 that we will move forward. Yeah. And I believe there's another institution or another program actually that mentioned that they might have 2 additional residents in the same situation, that the supervisor site is not allowing the rotation to be completed. So that's another $5,000 potentially. So these funds will, based on the rider authority, we can move those over to 21 and add that to the appropriation to make, the allocation for fiscal year 21.
So really the question, we are on assumption B because of the previous vote and not considering assumption A. So it comes down to funding for the FDC, and the options are 100,000, 50,000, or 0, 1, 2, and 3. Historically, the group I think has selected to continue to fund the FDC. I think there's been discussion about value. Many of the faculty in our programs have benefited from that program, and so that's been a discussion point. But I'm open the floor for further discussion or a recommendation.
Just a question, Mike.
Sure.
So historically, we've funded it. Is 100,000 what's been the historic amount?
That's correct. You'll see the figure from this last year was like 101,000 and some odd change. And a comment about that, Ernest mentioned this, but we had $1,000, $1,009, I think, to distribute. And rather than send that in small pieces to every program, we just rolled that 1,000 in to them where the funding could make a difference. And so historically, it's been 100,000.
Correct.
It has been for 4 or 5 years. It was 150 for one biennium when we first got funding back. And then last year, it was 134 because there was 34,000 left over from everywhere, and it was too late to try to distribute that even. And we were able to use those funds to beef up our library and that kind of thing. So we're, we always find a way to use the money.
Yes, ma'am.
I'd like to make
go ahead. Sorry.
I was just going to make a motion. So if you got a comment, please go ahead.
Well, I did. This is Dr. Warwick with Family Medicine. I'm going back to the future. It feels like this is 2011, 2012 all over again, looming and coming forward. So my following statement is not so much for this time, but I guess if any legislator or someone like that looks at this transcript, it'll be important to note that the FDC is important to the family medicine residency programs throughout the state. However, I can remember a decade ago when we went below a particular threshold in funding for the family medicine residency programs, and that funding level below 4,000 was, in my opinion, very disruptive to family medicine residency programs being able to fulfill their mission. I kind of came in here with a little personal feeling that my threshold is somewhere around $5,500, and that when we start to get to below that, we are going to significantly see where service and education, what is going to fall to the wayside is the education part. So what I'm trying to say is, Cindy, I am, and has always been, a supporter of what you all are doing, and I will continue to be so. But I am projecting moving forward that if our partners in the federal government, whoever that is going to be, comes back with funding levels that are similar to where we were in 2012, 2013, then I'm going to have to balance what is benefit, I guess, personally at some point in the education of my program, balance that with what the FDC can provide. So I just wanted to give a little understanding that I'm comfortable with the full level of funding this year. But if we are sitting in a situation to where we were back in 2012 and 2013, where in this pandemic post experience, that there may not be funding support available, I just want to know that we may have to have a little different approach for the FTC in subsequent funding years, because there is a particular level that gets to my concern for my program and for what I bet other programs when we go below a certain floor.
I think those are great comments across the board. And, I mentioned my worry about the economy. I do think it may be a challenging time. We just don't know. But I think there's reason to be worried. And I appreciate the idea of thinking about a threshold, and it's probably different for every program. But I think it is interesting. The analogy I would use, I think somebody had said more children, more mouths to feed would be my analogy. And I think before we've talked, I remember those discussions back in 2011, 12, 13 about the seed corn, the maintaining the seed corn of what we're trying to do. And that really is residency funding. And so I think priorities may change. And I think that you could say that also about rural rotations, public health rotations, in terms of how much money is allocated. Thinking about that, there's some ways to try and keep our seed corn alive, so to speak, in terms of the core residency. So it's great discussion points.
So with that, this is Dr. Warwick. I move to vote.
Okay. Do you have a motion for which funding you prefer?
Ernest, can you put that slide back up, please? Yeah, so I put a motion to accept option 1B.
Second.
That would maintain the funding at $100,000 for the FDC, which has been historically the levels recently that we've used. Do I have a second?
Second.
So I have a motion and a second. So we'll do the hand vote again. And you may have to toggle your participants to see it. Ernest, do you have a tally?
Yes, sir. We have 7 yeses. That is majority.
Very good. So that motion carries. So thank you all for that deliberation, hard work, and comments. And that concludes our 2 kind of key voting items. I think we'll move on to item 9, which is update on the Faculty Development Center. Cindy?
This muting and unmuting, I don't know how it can be so complicated. Thank you guys again for continued support and faith that you place in us. And remember, we'll do what we can to help you at any time. That's what we're here to do. I do remember the seed corn discussion, and I remember lots of hard discussions you all have had. And I appreciate that even the years when we were not given any dollars, we remained as an item on your budget at $0, so that when it was easier to bring us back when you did. And we really, really appreciate that. We use the funds to pay salaries. We offset the cost of salaries. I have to thank the Texas College of Osteopathic Medicine. The dean's office supports the rest of it, and into their state and local funds. They allow us to operate. So we operate not only at your pleasure, but at their pleasure. So together, we've been able to continue to carry on. My report looks just kind of like it always does. We got lots of numbers. Our big program is the Graduate Certificate in Academic Medicine Fellowship. And we have gone to where now we had 11 fellows this year. It's the largest class ever. When we get done at the end of this year, we have 200 graduates in, no, how many? I can't tell you the number all of a sudden. Total since we've been there, sorry. We had 200 in Waco. But that I don't think number is as important as that we've still got lots of interest. And still mainly family medicine. The numbers look that way. This year, we have an interventional cardiologist. Mike Reagan, do you remember your fellowship? Would that have been weird? It's just very different.
That would have been weird, yep.
This guy's great. His wife was a fellow last year, and every time she came home talking about it, he said, wow, that's some cool stuff. And he wants to start a fellowship. And we teach the kind of stuff that it would take if you wanted to just to start up a fellowship. Anyway, we really have a good time, as we always have. The fellows come away with great ideas and great knowledge, and we're proud of all of our fellows. I look around and I see our former FDC either in Waco or in Fort Worth, and these are the guys that are always at the top of their game. And I'm impressed with the things that happen post fellowship. But as I said, we still got lots of interest, lots of family medicine interest. Just still our core is family medicine. This year, I haven't finished the accepting process of who we're going to have come into the fellowship this year, just because my schedule's been up in the air. As you all know, you're planning things without knowing what's going to happen tomorrow. And that's kind of a typical way. I fly by the seat of my pants. I'm comfortable with that kind of thing. And so we're not sure exactly what's going to happen on campus, but we're going to continue the number of sessions that we hold. Some of them will just be virtual. And I have to say, I was scared, whatever, kind of spitless, if you can imagine. I just haven't done a lot of this Zooming and meetings. I wasn't convinced that you could have the same kind of closeness that you have face to face, and I'm wrong. Now I am the boomer zoomer. I believe in this stuff. It's going to happen. You can do more. You really can do more. I still want some time together as a group, like for the fellows, and we'll probably meet the first session and the last session in August, and then again in June, and maybe somewhere in the middle. But I can imagine how much cheaper that is going to be for the investment from the program, because the travel is what's really expensive for somebody to send a fellow. I mean, those of you who have done that over and over again, it costs a lot to send somebody to the fellowship, even when there was no fee for it. It's now still very affordable as far as that kind of education goes, but it still costs money. So we had our April session of the fellowship, just by force had to be virtual. And we did 4 days. I hosted it right out of this room, and it was great. As a matter of fact, that some fellows commented this, and it happened to me. Every time I put them into breakout rooms, I thought they were getting up and moving around. And so I wasn't that conscious of how numb their rear ends were getting, because I didn't say actually stand up when we're going into the breakout rooms, because you need to be moving around. And I forgot we weren't all in Fort Worth together. A couple times I really thought we were in the room together. It is, if you let yourself be in the moment, it works. I'm jumping into our other numbers. I'm more than a little nervous about what's coming up on Friday and Saturday, but it's going to work great. We have the Chief Residents Conference, and there are 140 people registered. And the biggest thing is the moving them around into all these different breakout rooms. I have to get them into the breakout rooms and then have people facilitate those. And we finally figured out how I can get facilitators to jump from room to room. But I've been consumed with this stuff. And but 140 folks. Last year, what we did at the 2019 Chief Residents Conference, kind of at the 11th hour, we'd had some program coordinators that were interested in coming. We ended up inviting program coordinators and program directors to the Chief Residents Conference to share part of the programming, given that this is the leadership team for the residency program. It was great. It was great. I have to tell you, you all know that residency coordinators are incredible. The stuff that they do just blows me away. They broke off from the main session and went into their own stuff, and they ended up creating this incredible planner for any residency, any specialty that leads you through the year of the stuff you got to do if you're going to run a residency program in this country. And they're now I think there's about a dozen or so last year. I'm not sure I can look that number up, but there was 11 coordinators in the meeting last year. Now there's going to be 24 of them this year, but they're sharing that planner with everyone. And I can't imagine what kind of tool that is, particularly if someone is new coming into that role, because that's a very complex role, as you guys all know. So we've left it open to coordinators and program directors. We have one director this year. We had 3 last year. But of these 140 folks, 78 are from Texas and 75 are family medicine. So we're absolutely serving even more people than we have in the past by doing it this way. We're not charging any fees this year, which I think might have a little to do with our subscription rate. But we decided that was a really good move to buy us some goodwill for future. I think we can actually make some money off of this, or at least, keep the coffers from going completely dry. One of the things that's so cool, unfortunately, that we miss the time together, but we don't have to feed anybody. And we don't have to rent hotel rooms. I mean, there's just a lot of stuff that makes this so much more doable from our end as far as what the expenditures actually are. And given that we couldn't travel at all this whole thing, none of us could travel. So we didn't get to do our professional development, which is unfortunate, but we also didn't spend that money. So that has been, however, it's been moved around. That was from other Dean's other funds. But so far we haven't had to let any staff go. We've been able to maintain our staffing. We'll see how that continues into the future. I could just talk forever, you guys. So you'll have to get me back on track if I've lost any of you with this. The numbers are in the report. We're continuing to do the same sort of thing as we've always done. We are still available, as we always have been, to come to any family medicine residency program or department and do what you need to do, what you need us to do. We had a really great session down at Memorial in Houston in January, I think it was, where we went and talked about residents in difficulty or a resident with a problem. We had 17 maybe faculty that showed up. It was one heck of a great workout. And Sharon Manson, who is my colleague, and I did that together. And it was really a great session where the faculty left there with some real tools to use. And I love those kind of sessions. They feel so great. And it's fun to go know that we really are supporting individual programs as they need it. So don't forget that we're available for that sort of thing. I'm just anxious to see what happens this weekend, this Friday and Saturday. As I said, we have 140 people registered. We'll have, I think I have about 8 or 9 staff from kind of around the dean's office that are going to work as facilitators for us during the session. And we have 12 speakers who then also have to be juggled and kind of trained. I will say that in the fellowship, when we did the virtual 4-day session, only one of the speakers, I think we had 5 speakers, they're the great ones, only one of them is younger than me. So I couldn't believe it. Here's that most of these guys have retired recently or just retired, like Roland Gertz and these guys bring the greatest stuff that you can imagine. And we all did great using a technology that was, frankly, most of us weren't familiar with at all. But I'm pretty impressed with what people in this country have done with the technology so quickly. It's amazing if you stop and think about what we've done. We just turned the whole thing around. The new normal is a good thing. So does anybody, did I answer any questions, or does anybody have any questions for us, for me? So
I can see you talking, but I don't hear anything.
Sorry about that. That thing mutes itself, I guess. So Cindy, thanks for your comments. I appreciate the updates on COVID and how that has impacted you and the technology. We do have just a couple of minutes, and we have one more item to consider, and that is the future meeting dates. And Ernest, do you want to walk us through that?
Yes, sir. Spoke with Dr. Silverman yesterday, and the suggestion was to possibly hold a meeting in November, possibly November 4th or 5th, or even the week after, 11 or 12th. That's a Wednesday, Thursday. For some reason, the Wednesday seemed to work pretty good for the group, for most days. So since next year is or January, we'll have a session in a legislative session. So it'd be good to kind of meet and discuss, the priorities of the program, and get those numbers and that discussion going, so that we can prepare, our request to the legislature, and then possibly a meeting after the fact, just to kind of get a status update on where we're at in terms of funding. Stacy, I'm not sure what the legislature is going to look like, but I know it's going to be a difficult session.
So I'll just chime in and say, yes, it's going to be really rough. We all know that. And, I appreciated looking at the numbers from the program over the last 20 years, and know that internally I'm forwarding numbers now to look at. And this program is critically important to the state. And I will make that case as well. The other item I want to make sure you all know about is that you do receive formula funding. Your program may not receive it, but there is formula funding that is generated, and it went up a little bit this time around. I think it's up to about $5,900 per resident. We can get you the actual numbers in the General Appropriations Act, but I wanted to make sure you knew about that. And there's actually one more thing I wanted to just touch on briefly for you, just to make sure you all know about it. That is the passage last session of the Texas Child Mental Health Care Consortium. That group is, it was given funding of $99 million for the biennium, and it is just beginning to do some of its standing up of its programs. And I want to make sure that you all know about it. So there is a website, if you just go out, and it's the Texas Child Mental Health Care Consortium. And there is a way for primary care physicians to work with specialty psychiatrists if they have an issue where they really need to get in contact with someone. So that's called the Child Psychiatry Access Network. And it's headed up by Sarah Martin from Texas Tech University and Laurel Williams from Baylor College of Medicine. But I wanted to let you know about that. That's really an initiative for primary care providers to get a response within 5 minutes. And they'll be connected to a child and adolescent specialist within 30 minutes. So just wanted to brief you on that.
Thank you. So 4th or 5th of November is the proposed. I'm going to say, let's propose November the 5th. That is a Thursday. Does anybody have any big concerns about that date?
If it's in the morning, that's a no-go for me. If it's in the afternoon, that's fine.
I don't think there's anything that specifies we have to have it in the morning.
No, sir.
We could do it in the afternoon.
This is Danish Pretty. Is there a possibility to just keep it on the Wednesday mornings, the way that's usually scheduled? Which would make it the 4th?
We could do it the 4th.
And actually, any day that week will work. I mean, whatever's best for you. Those were just dates I picked out because our meetings are normally on a Wednesday or Thursday. So that's where I started. But I'll entertain, any other dates.
So
we're
if
pretty open.
if we have it as a Zoom meeting, I could do it on the 4th. Wednesday
Okay.
morning.
And Stacy, I'm not sure if we'll be back in the office. I mean, I'm sure we will be back in the office by then, but could that still be an option to do a virtual meeting?
So I'm just going to say, I don't know that the agency has made a decision, but I think this is a great idea. And I think this meeting has worked really well. Please provide your feedback and let us know. But I think anything that minimizes folks' travel while still getting their input is wonderful. So I will be encouraging that throughout our agency.
I agree.
So let's go with 10 a.m. on November 4th, barring anybody raising a big ruckus about it. Does that work?
Yes.
All right. Very good. And really, we've completed all the agenda items and we're just a touch over time. So I want to thank everybody for their attendance and comments. It's been, I think, a good format. I'm pleased with how it went. I think we got good business done. We got good discussion points out, just as if we were face-to-face in Austin. And so thank you all for that. Ernest, do you have any closing comments?
Yes, sir. I'm going to follow up with an email and I'll send the committee the annual written report summary provided by Dr. Reagan, as well as the funding scenarios that were approved and any additional materials that I need to send out, including the FTC summary as well. I too want to thank everybody for their flexibility and their patience. This was a frustrating run for me because this is the first time we've actually hosted an agency Zoom meeting that's streamed live through the YouTube process. So up until last night, I was a little skeptical that I was going to get it to work because we also have another concurrent meeting going on. So luckily, it all went well, and I appreciate everyone's patience and assistance and for being here. So thank you very much. And if there's anything we can do, of course, reach out to myself, Stacy, or Cindy Fisher, and we'll do our best to answer your questions or get back to you with the appropriate assistance. Thank you very much.
Ernest, thank you. You did a superb job and appreciate your support.
Thank you, sir.
And I want to thank you all again for your support. I don't know that if I made that clear enough, but it's incredible that you all continue to stand behind what we do. Thank you. And Ernest, you did do a great job.
Thank you.
Brain.
All right.
Thanks, everyone.
We're going to call us done then. Thank you all.
Thank you.
Thank you.
Great job, Dr. Reagan.
Yeah.
Take care.
Bye.
Thank you.
Doctor.